It's good. Should be good every day. Make it happen.
No, we'll be back up. Probably be a little different. Oh, yeah.
Okay, Carol, are you ready?
I'm ready.
Okay. So let's go ahead and convene the September meeting of the Greater Columbia Accountable Community of Health. Happy September, everybody. And back to school, back to labor after Labor Day. Everybody but Dan.
Hey.
So let's go ahead and start with
Dan's laboring every day.
with the introductions. I only pick on him because he knows I like him so much. I'm Rhonda Hoff, Yakima Neighborhood Health Services, representing the housing sector and chair of the GCACH. And so we'll start counterclockwise, I guess, this time.
I'm Lauren Johnson. I'm with Greater Columbia ACH.
Caitlin Safford with the Mayor Group NCO representative.
I'm Corey Bliss, sitting in as a guest for Lori Brown, Southeast Washington.
Hey, this is Darlene.
Hi, Darlene. We're just getting started.
Great, thank you.
If you'll speak up a little, she can.
Hi, I'm Les Stallmacher. 123.
Les.
Education.
Thank you, Les.
Hi, Sandra Flores from Yakima Valley Farm Workers Clinic representing X2HC.
Jenna Shelton, Greater Columbia ACH.
Martin Sanchez, Greater Columbia ACH.
Carol Moser, Greater Columbia ACH.
Julie Peterson from Kittitas, representing hospitals.
Wes Lucky, Greater Columbia ACH.
Ronnie Bachelor, Mouthful of Food. Lutheran Community Services.
Great. Dana Ferguson with the Allied Health Center of Excellence, with the community college system representing workforce development.
Adam Davis, Puget Sound Fire. Rob Arnold with the Health Science Project.
Ruben Peralta, Greater Columbia ACH.
Becky Coleman, Greater Columbia.
Diane Halo, Greater Columbia.
Patrick Jones, Eastern Washington University.
Ruben Alvarado with the City of Pasco, representing local government.
Kevin Martin, Kittitas Valley Healthcare and Kittitas County Health Network.
Great. And who do we have on the phone? I heard Darlene.
Yeah, Darlene Darnell, Catholic Charities, representing faith-based organizations and child and adult food care programs.
Okay. And Megan, are you there?
I am Megan DeBolt, representing Public Health from Department of Community Health in Walla Walla.
Sam Wardell, Greater Columbia.
Great. Dan?
Yes.
Yeah, Dan Vizzini calling from the Center for Evidence-Based Policy in Portland.
Thank you. Heidi?
Yep, I'm Heidi Bertu, Center for Community Health and Evaluation, and I'm your evaluation partner.
Great. Sam, was that you a minute ago?
Yes. It's Sam Wardell, Greater Columbia.
Great. Can you scroll down a little bit, Lauren? Okay, is there anybody on the phone that has not introduced themselves? Okay, great. Okay, well, welcome everybody. We start the meeting as always asking everyone to review the attestation of conflicts of interest and also our policy on self-dealing transactions and the prohibition and standards for approval. And so looking at the agenda, I would ask if anyone sees anything that appears to be a conflict of interest for themselves or their organization. And it appears not. So then we will go ahead and look at the consent calendar, and we have on that the board meeting minutes. And so hopefully folks have had a chance to review the board minutes, and those are well detailed as always. So thank you, Lauren. Appreciate your attention to detail on the minutes. And so those will be accepted unless anyone has objections to that.
My only comment is I'm glad Ed Watkins, I believe he abstained on the committed office funding as well, and it's not noted.
Okay, good catch.
I'm not sure that he did because he you can ask Ed, but we asked him in an email. Oh. And I think he did vote on that.
I think I've seen in the meeting that I may have unintentionally voted by email. So both conditions are true.
So how should that be reflected?
I don't know which one you want, if you want to pick one or not.
Yeah.
Oh, I should have, we're recipients.
So officially you want to abstain?
Yeah, I don't think it will change the outcome.
Okay, it won't.
I apologize if
Okay.
that is in fact what happened.
Thank you, Sandra, for catching that. Okay, so Carol, we'll move on to the reports and updates.
Madam Chair, I think that because we have so many guests here today, I would like to refrain from giving the report till after they've had a chance to talk. I know that they have to go back on the road. So I think we can move right to the Health Commons project.
Okay. So then Dr. Martin and Rob and Adam. It was an A. It was just hard to come out with the rest of it. So we're going to turn it over to you to introduce the Health Commons project.
So Rhonda, were the minutes
You want me to?
The minutes were approved.
Okay, I'll kick it off here. But, good afternoon, everybody. Thanks for taking time out of your afternoon to have lunch and get to know a little bit more about this project, this initiative that we've been working on. I know many of you were in the earlier presentations, so this will be a much briefer.
So let me just ask Rob, can the folks on the phone hear Rob okay?
So Rob,
I
why don't
can.
you come over by Rhonda?
Okay. Actually, there's a chair right over here, so that's a good.
Okay.
Either one.
Oh, you can go into the other one.
No.
Wow.
Sorry.
Oh my, that's one short chair. There we go. Yeah, exactly. Well, again, thanks everybody for giving me the opportunity to talk a little bit about the Health Commons project. And I know many of you were at the earlier presentation with the Leadership Council, so I won't go over every detail, but this project came up out of work that I was doing at University of Washington, and on kind of healthcare innovation, and I'm a software person by background, so if you hear the occasional technical jargon or something, please forgive me in advance. But the idea was to start to collaborate between University of Washington, some of the resources we had there, and I first started working with the governor's office. So if you were familiar with Dr. Bob Crittenden and Dr. Dan Lessler, I had contacted them and sat down with them. I said, "What's your biggest challenge?" And they basically came back and said behavioral health. This was at the top of their list at the time, and I was also trained to ask the 5 whys. So why is that a problem, and what's going on and stuff like that, to try to better understand it. And again, I'm not a provider, so I wasn't trying to understand it necessarily from a clinical perspective, but just saying what's the problem and where are their bottlenecks, and thinking through what from an information technology perspective could we do to assist that problem. To make a long story short, Dr. Bob connected me to some colleagues of his in the Olympic Peninsula, Joe Rozak at Kitsap County Mental Health, and then eventually Elia, who is now the executive director at the Olympic ACH, and through a variety of different conversations and all this so forth, we started getting down to what are some of the real challenges behind it. And there were major issues regarding how do you integrate services and so forth, but there were also some very fundamental problems regarding communication between these different providers and organizations. And that was something I could start to wrap my head around. And so this turned into kind of a lot of discussions with providers in the Olympic community, and then discussions with the OCH, and it actually started to develop into an idea, and Carol would probably remember this, but it had a lot of different names. As classic software, we were immediately, the minute we finished version 1, we're immediately on version 2. So we started really kind of thinking through, if we're going to be able to help these providers better coordinate and better communicate information, in essence, integrate the services, but also make sure that we can have information flow between these organizations. So with the idea that we're really trying to get a whole person characterization of what someone needs and then organize the services around that, and then figure out how to make sure that the information is available to the person that is now in the lead position to provide the next service. And so through this work, we started with a project in, it was a very tough area, in medication-assisted treatment and substance use disorder counseling. And because you're also dealing with very important confidentiality issues in that particular domain. And we had this wonderful group of providers in Clallam that were willing to take this journey with us, because I didn't know what the answers were. I only had questions, and so once I started to really unpack what the problem space was, and the state of the art for communication was the fax machine, and then the next version of state of the art was we're going to use the EMR to fax something to the next person. And so that was just a real, that was kind of heartbreaking to hear that was the best we could do. And so we started really digging in and doing a lot of research on, what were other communities doing. It turns out in the U.S. market, we actually don't do this particular form of coordination very well. I guess that's not a big surprise to folks in the room. It's a lot of manual curation of information and stuff. And I just happened to go through the literature, and it was a New England Journal of Medicine article about this concept called e-referral. And I'm like going, well, that sounds interesting. So read, and start researching even further. And I found a partner in Canada that had not only launched these fully integrated programs in Canada, because there's a single payer system there, but had also launched and expanded in the UK through the National Health Service there, and then launched and expanded in Australia, and then just won New Zealand. So this was an established vendor that had really a tremendous bandwidth and capability to be able to do these things. They had already been through ISO certification and all these wonderful steps. And so I contacted them and I said, we're working on some projects here in the state of Washington. Would you and I went to the leadership there and said, would you consider working with us and collaborating with us? And he goes, the U.S. health system? Are you crazy? So, they apparently had done a couple laps through the U.S. market, and they were like going, yeah, we went through that Cuisinart. We're not going to go through that again. So it was after a few, soft persuasion and just saying, no, we're trying some new things here in the state of Washington. Would you please be willing to give us a try? He just said, okay, but short leash. And so, that was at their expense, by the way. They got nothing for it. And I just said, let's come up and see if we can create some workflows and see if we can make this work. And they knew there was no promises of anything out of it. I just said, you're at risk on it. If it works, it works. If it doesn't, it doesn't. And we put together some pilot tests and configured the software in a way that really made sense to providers. And that was kind of the genesis for just saying, including the EMR integration. It was pretty involved what we ended up doing there. And the providers in Clallam were so excited that they're like, we didn't even know this was possible. And I just said, well, the tool was hiding in plain sight. We just had to kind of figure out where these technical pieces were, and then figure out how to configure them. So that's kind of the origination of this particular project came through that. And then Elia knew Carol and Wes really well, and it sounded like you were all kind of struggling with similar issues with regard to, with the transformation waiver coming through and the decision-making process around the more structured pathways of model, which is not technology, but a model for being able to deliver care, and starting to think, are there ways to kind of incorporate care transformation and technology as one? And I can just tell you as a software person and somebody who's spent my entire career in figuring out information systems and the flow of information, if they're siloed, they don't work. If they're integrated, it works. You know, just like people, when we communicate and we're integrated in our communication, we do better. Same thing with technology. If we're siloed in our technology and we don't figure out a way to make information move, we don't do as well. And healthcare has really struggled with that issue for a whole variety of different reasons, which you all know. But, you know, we're at this point technologically where we can start to use tools like this particular tool out of Canada, and there's so many available in the digital toolbox today. And so we've kept working on this process, and you're going to hear from Dr. Martin about the work that we're doing in Kittitas. But you know, what I want to encourage people to think about is that the hard work is your care transformation. To figure out your processes, your turnaround times, your standard operating procedures, that's the majority of the work. It is possible for the technical people to come in and make sure that the tools will work right, but we can't do it unless we know what the transformation looks like. If we don't do it this way, we're going to end up with more systems like you currently have. So we're hopeful that we can you know, take on you know, some of these really challenging things and at least make the information technology not one of the pain points you have to deal with. So I'll park there.
So when what was going on in Kittitas about the time that Rob approached Wes and Carol was we've had the A team in place doing community care coordination for about 2 years at that point. And we were working to collate the data that we'd collected to try to get a handle on our outcomes. We'd been collecting data, but at that point hadn't even bothered to count how many people we'd seen. And the first count we made was exactly 100, and over the course of 3 years. So our care coordination group is a community-based ad hoc group. Most of you heard me describe it earlier, with representation from the 2 large primary care systems in the county, the 1 skilled nursing facility, all 3 assisted livings, hospital social work. Hospice has been at the table at different times. Kittitas Valley Fire and Rescue, as well as Kittitas Hospital District 2 EMS, aging and long-term care. More recently, we're pulling in people from the school districts, from law enforcement, from Central Washington University. And really what the group, without going through the whole creation story again, we started, it was a group that came together to solve a problem that never materialized. And the people in the room discovered that they had other mutual problems that they had the right tool set to address. And so they started trying to intervene with people who were failing in the community. And the best marker we had for who was failing was how many EMS runs they had. And at one point, it was literally our community paramedicine captain going through his logs and saying, "Criminy, we went to the same address 4 times. What's going on?" And a lot of those were people that didn't get transport. They were fall assist, so they were invisible to the system. You know, the PCP doesn't know about it until they show up in the emergency room. And of one individual, they did 15 runs, 14 were fall assist, they transported once. Well, if you see somebody show up in the emergency room once in 3 months, that's not a problem. But when you find out that medics are going out 15 times in that time frame, that if there isn't a problem, there's going to be soon. We were able to send a nurse from CHCW out to the home. I went out to the home. Community paramedicine went out to the home. Didn't take long to figure out that the problem was the guy had a double wide with 2 steps up and no railing. And if he fell on the steps, he couldn't get himself back up, so he would call medics. We worked, that one was with a local volunteer services organization, and they built him a ramp, and we didn't hear from him for 18 months. It's an invisible savings because the cost wasn't really visible to anybody, but taking a $1 million piece of equipment out of service 15 times an hour each is a real cost. So we recognized that we had these tools, and we wanted to get upstream, to try to address people before the medics were making runs. And we wanted to be sustainable. We knew in order to do that, we'd have to collate the data we've been collecting and present it. Despite your caution earlier, I do still apologize to the intern who I made learn Microsoft Access. But that was our first real attempt at data collation. It was precisely that point that Carol called and said, we've got somebody that can work with you work with your IT subcommittee on how to collect the data and how to manage folks through your system. So right now we're piloting a single case based. When we look at our data, we find that we have two real types of patients. The first are people with significant mental health issues. And for the most part, once we get them connected with mental health and stabilized, they're really only on our radar screen for 2 or 3 weeks. There are other individuals who, for one reason or another, don't fall in the purview of our mental health providers, who are exercising their autonomy in ways that are injurious to their health. And those are the ones that we wind up taking care of. Well, there's one that we've had on our radar screen I've been with the group 2 3/4 years, so she's been a subject of interest for at least 3 years. Some of the things that have been done to keep her safe involved alerting the police department as to what her route was to and from McDonald's for breakfast and when she usually went, so that they could wait for her to go through a stop sign, which she invariably did, and take away her keys. Later, it involved getting an infested sofa out of her home before it became a health hazard to her. Most recently, it involved working with her primary care team to present to the courts and get a guardian ad litem appointed, so that we can try to really address what's going on in this woman's life. We thought that it was probably unreasonable to run that kind of referral through the software as a test case. So we went with let's mock a patient from the emergency room through processing the referral, analyzing the needs, referring to mental health. Once we've done that, Rob likes to talk about assembling Lego blocks in the proper order. Then we can start talking about adding additional points of entry. And some of that may be from the primary care clinics, and what I heard you saying earlier is the possibility of creating orders in our EHR and CHCW's EHR so that it's a one-click to make a referral to the team for assessment. And I would imagine that order would generate a CCD that we would then ingest and process. Eventually, I would like our city librarian, who sees most of Ellensburg's homeless population first thing in the morning, to have access to make referrals when somebody's failing, when she sees a changing condition. We're a ways from that, but we want to broaden that. We need to have a point of entry for the schools. I had a lot of years' experience with the Auburn Food Bank and learned firsthand that often the school counselor is the first insight that a family is failing, whether that's food insecurity, domestic violence, substance, income instability. Being able to have that access from that portal is important. So that's kind of the tool set that we have, our journey to this point, and where we're hoping to go with it. And all of which really would have fit better had we pursued Project 2B, but again, by considering transitions at a high-risk event, to deal with transitions, you have to have care coordination tools in place, and so this becomes the backbone for that work as well in our community.
should have asked this earlier, but are you currently using the tool?
No. In fact, did you put screenshots in the slides? Is that?
There's like one screenshot, but there's different screenshots in there.
So we're on our second iteration of interface work. We haven't really prototyped a working version yet.
Although it's in your inbox.
So it is in my inbox.
We actually have.
it has a lot of very good companies.
Yeah. So the system is now configured based on the use case for redesign. So the way the use case works is there's some forms that are set up in the system where community paramedicine can do an in-home visit. They can collect some basic information about the individual, including some behavioral health screening. The way the referral work, and they can do all this from an iPad. And this is perhaps a little bit more controversial, but we're using the iPad's camera and video capabilities along with it. So if they're out at the home and they need a ramp, they can actually take a photo or a video of that. All that can be ingested into the system along with the basic information around what the need is. And then that gets sent to Dr. Martin. Dr. Martin will do his analysis and his assessment of it. And if he determines in this particular use case that there's behavioral health needs, then a referral would be sent from Dr. Martin's team to Dr. Kramer. And then Dr. Kramer has the benefit, and we worked with Dr. Kramer to make sure we knew what his intake looks like, because it's not as simple as just saying, here's the last record of information we have on this individual. You really have to get a full picture of what's going on. And, if a referral is coming in for Dr. Kramer, a lot of times, it's very incomplete information, and they have what they use called a face sheet, but essentially it's a very limited amount of information. And so their process is to send a letter out to the individual and see if they're willing to engage. At least in this case, they're getting a very complete set of information. And if they needed help through community paramedicine or some other agency to make that human connection, they're going to know a lot about this individual in their case.
And one of the things that we're trying to build in is the idea of structured access, so that if, for instance, we're making a referral to Hope Source for housing, the information that they need is different than the information that Comprehensive or Valley Psychological Services would need, is different than the information that the primary care team would need, is different than one of the partners in this is the shop class at Ellensburg High. They make a lot of our ramps. They don't need to know all the diagnosis. They don't need any clinical information for that. They need zero. They love a picture, though. Yeah, exactly. So it's kind of interesting to think we're using this in a lot of ways. There's a lot of things we hope to get from this. One, the ability to track referrals through the system and make sure the loop gets closed. Two, as an intake tool, one of the things that is built into that data that the community paramedics can gather on scene is the American Academy of Family Physicians instrument for screening for social determinants risk, and going through some basic questions about income stability, food insecurity, and so on, violence. I don't like their screening tool for violence because it is possible to answer that screening tool. Yes, I've been injured in my home several times and not flag on the screener. It's one of the more bizarre instruments I've seen. But with that caveat, obviously, when that referral comes to our coordination group, the A team, and we say, yeah, we need to send this on to Comprehensive, we need to send this on to Ellensburg schools so that they know that they've got a kiddo at risk. We also intend to use it to collect the data and demonstrate that we are in fact making a difference, rather than just being able to point to the guy who stopped falling for a few months. So we're excited for what we can do with this. And one of the things that I think is probably one of the best harbingers of where I hope to see this go is that 3 years in, and everybody who's come to the table is still at the table. Nobody has said, this doesn't sound like it's worth doing. Tell me when you've got a product.
Adam, do you have comments?
Sure. So my name is Adam Davis. I'm a family nurse practitioner and psychiatric nurse practitioner by trade. I work at Puget Sound Fire and lead a community paramedicine or mobile integrated health program, and have been working with Rob, Elia, and the folks at Greater Columbia ACH on the Health Commons project for the last 12 months or so. We were in a similar space as Dr. Martin describes with our program. We, just like many of you, were trying to provide that whole person care in our community, try to take care of people better, and trying to figure out how do we work with different health and social service agencies in our community to try and work together as an integrated team to provide better care. So we, would go out on these 911 calls, low acuity calls, and try and connect people with the right care, or identify high risk, high utilizers, and go out and proactively visit and try and connect them to care. We're continuing to do this work and showing great progress, but what we came to realize is that it's very challenging to do this work from a provider standpoint. Doing the care coordination in between agencies is just very challenging work. And on the analytics side, on the tracking side, we have a hard time demonstrating our impact and really seeing, what are the outcomes that we're moving, not just kind of process compliance with getting people the right care, but what actually are clients heading down the right path. So that's when we got matched up with Rob and this idea of the Health Commons project and a network of a communication network for providers to coordinate and track care became really appealing. It was, the idea is that it's a vendor agnostic system. So for Rob and the people he works with, they're not interested in a particular tool. They were just interested in learning about what success looked like for our group and what kind of care transformation we were trying to accomplish, and then matching the technology to that group. So we really see this as a way of moving beyond the pilot phase for our transformation into more of a production phase. We're hoping to roll out our community paramedicine service across other fire departments in the community, and the technology piece is an important way for us to get there.
So are you using it with a specific population currently?
So we are still in the design phase. At the end of the day, where we hope to be in 4 years from now, is to have a natural community of care, is the terminology they're using in Olympic that we've kind of adopted in South King County. And what that really means is a connected and sustainable system where health and social service agencies are working together as an integrated team and communicating on a common technology infrastructure. To get to that point, we're still in the phase where we're bringing that initial group, that minimum viable group together to say, yes, we want to work together. We see this as beneficial for all parties involved. And here are the specific workflows that we want to design for this system. So, for example, ER discharge to our community paramedicine team, community paramedicine referral to and street-based case management, community paramedicine referral to behavioral health. Design those workflows and then really start to put in the technology. We are planning to do a pilot test of the technology this year, but a lot of the hard work is really just getting the agencies together to agree that this is what we want.
Other questions?
Yeah, any thoughts about how this would interact with local government, like police or things like that, to perhaps identify if there's a certain household with a higher risk, and perhaps go in with a different approach to the situation, obviously?
Yeah, I was going to say Adam or Dr. Martin might be the technology can definitely interface. It's really the care services.
That's one that we hadn't addressed per se. We'd looked at law enforcement as a referral source, but we hadn't considered the very real probability that we could help diffuse a situation. We're going to look at that. One of the other things that we've done that is independent of this, but eventually would probably be incorporated into it, is we have countywide single dispatch for all first responders, and we're working with KITCOM. We're working with KITCOM to maintain a working list of hospice addresses so that if they do get a medic call from a hospice address, the medics know the address is flagged in the dispatch, and the medics know to call the hospice nurse en route. And a lot of times the hospice nurse can be on scene with them and prevent an unnecessary transfer that way and have a direct impact on the care in the field.
Yeah, in South King County, there's a program called Law Enforcement Assisted Diversion, which is a group of police, the prosecutor's office, and then a community agency, I think a case management agency. And what they do is they identify low-level offenses that they would like to divert or avoid prosecution. And so they bring those individuals to the police station, and the police station, they're met with a case management, and they have the option to be rerouted from the justice system. And then there's also another mechanism where there's an ongoing list of individuals that they're doing outreach with. But this is certainly, another service transformation that we could see connected into the community.
Yeah, and up in Clallam, Department of Corrections, so it's not exactly the first responder side, but Department of Corrections has been part of our integration test. And so, and it was brought up earlier around 42 CFR Part 2, and essentially the handling of this type of information as you interact with law enforcement has to be very careful. So, and the SUD providers are extremely sensitive about, any kind of information disclosures, as they should be.
So, to that point, is there a definition you're trying to avoid that would make you an EHR and subject to, 42 CFR Part 2 and all the business associates agreements and
We
that?
have to do all that.
So the shop class at Ellensburg High School, this is what needs to happen, but it seems like as soon as you consider it an EHR, you have all this burden.
Well, what's interesting
Not
is
the EHR itself, it's the content of what's in there. So if you're not putting protected health information, you'd be fine, but there is protected health information. Yes.
But, and without getting geeky here, there is this thing called roles-based access control, which means that who you are and what properties you have gives you access to information. So it is possible, because we already know in several different areas, you have social service agencies connecting to a health system's EHR. So, and the way they manage that is through this thing called roles-based access control. So the user has a very specific set of views of data. So disclosure of, basic demographic information is a lot different than here's a lab result. So, and again, there's as part of this project in Olympic, the great news is because they're now at the point where they can start going live with the technology. And so we're working with the community on essentially what the data governance policies are and making sure we understand very precisely. There's no, we have to know what that policy is, because we can configure the system very easy. We have to know who we're enrolling, how we're enrolling them and stuff. So that's the big conversation we're having there. So as we're just starting to now get into the user experience of what the software works like in KITCOM, they've already passed that point, and they're looking at what does the governance look like for this natural community of care.
And to your point, what the shop class sees isn't a view into the EHR, is a work order.
Yeah.
They'll get a name and an address, and we need a ramp of X dimension.
level of personal information travels on Amazon daily. So it may be coming from a different source, but what's protected and how it's protected is actually a really interesting question.
Lauren, can you move forward in the slide deck to the screenshot of the software if it's in here? Just to show people what it looks like, at least in the implementation in GCACH.
This one is in Clallam.
Or Clallam, sorry.
Yeah, and there's, and I showed different screenshots.
There we go.
So these two components here are built into the referral system itself. So this would be an example of, here's client details, here's order types, places to upload files, and so forth. And then there's a pretty comprehensive thing. And then this is a tab where you send and manage referrals. And then this is the kind of analytic information you can pull off of the system. So the reason why systems like this are more powerful than just sending a fax is because we can track the states and the statuses of each order. So think about, any community is basically a set of capabilities and capacity. So if you're overloaded in one place, you want to redirect to your order to a different place. You want to know wait times. You want to know, this is all kind of, other industries have done this, by the way. Healthcare hasn't quite got to this step, but you want to know your capacity. You want to know your inventory. You want to know what's going on so you can efficiently route orders to the right place. And so we have those kinds of, not only the referral mechanisms, but also the analytics on the back end to be able to do this. So it really does help you with some of your population health interpretation.
Just as an FYI for our implementation, I'm not sure if I want everything as pie charts or nothing as pie charts.
The good news is all configured.
It depends on what I want my lead hospitalist head to explode. The more pie charts we put in, the more likely.
Yeah.
But basically, as you're building this, it's being built with the rules of the EHR in mind and the exchange of EHR.
Yeah, absolutely. And so this just happened to be the EHR that our partner uses. By the way, there's no PHI on any of this. Right? We're very careful. This is, I think, Mickey Mouse. But this is
Mickey Mouse has rights too.
We got to protect Mickey. But this is the standard EHR. This has to be practice partner. And I think we were talking about earlier, essentially it's an order mechanism where in essence they place an order for SUD treatment and that fires off a referral to this system, which is then processed by a navigator and then sent over to the SUD partner. And they can send, the provider here can send the referral and that referral would be received. It could be accepted, rejected, it could be asked for more information. So it really is a communication tool.
So that upper left screenshot is from pre-manage.
Yeah.
And how does that incorporate into this?
So what we're envisioning, and we haven't done the actual integration yet with it, but I've been working really closely with that team. One of the things we really love about the pre-managed system is the unique identifier, right? And so it's pulling across a large population and so forth. So I think one of the questions was asked earlier about how do you make sure you don't have referral collisions and some of these different things, or you're mistakenly, replicating an order and stuff like that. Part of that is solving it through the unique identifiers. And pre-manage has a very sophisticated algorithm for matching. And so we really, really like the work that they've done. No system's perfect, but they've just done, in my opinion, just a great job.
So somebody is given a referral and that's sent out to the doctor or the referral agency or whoever. And that referral isn't followed up on. How do you, where's the bells and whistles for not falling through the cracks?
So there is this procedure in the software. So when a new order is sent, whoever's on the receiving end, kind of the point person, usually a navigator, will get a message. You have a new order in your system.
Mm-hmm.
And then we can tell if that order is not responded to, we know exactly what's going on with that order.
Okay.
It's just like any other supply chain or logistics.
If the consumer doesn't engage in those services, what would be the follow-up in the system for sending somebody out, checking in or checking up on.
Well, in the case of, let's say, community paramedicine, if you were concerned, it's like, uh-oh, you know, this person didn't
Didn't show up
engage.
for an appointment.
I'm going to fire off a referral to Adam or Kevin would send a referral to community paramedicine. Can you go do a site check?
Mm-hmm.
So there's ways to, you know, it's Kevin's intelligence on the back end kind of looking at,
And then
the system can't solve all those issues. You still have to have human intelligence routing these things.
So the police department question, because I was curious as why, kind of my understanding is they weren't being considered.
Oh,
They
the police
do
not being?
the police department.
Um,
Well, the reason why I'm inquiring about this is because the police department is a first responder, but my experience with the police is they do those well checks. They do. If you call them and say, "Hey, my mother-in-law is not feeling well. She's not responding to phone calls. Can you check?" And a lot of times I've done that to have them do a well check, and they do.
That's awesome.
And a lot of the officers that I worked with out on the street, there was a lawsuit that came through True Blood. Okay, the state of Washington was being sued. I don't know if everybody knows that or not, but now it's about detainment and getting to services for evaluation. That's just kind of
For competency to stand trial.
exactly. So what they're trying to implement right now is peer support in that, and having someone come out with officers. But the officers are usually first on scene, and my involvement with them has been, do you want to take them to the hospital, even though they've committed a crime, but they're not going to force that because there's health risks behind that, and they're not going to get the care incarcerated as they would if they went to the hospital. So they do make those decisions online as they're working and as they're having those engagements with people.
Yeah.
And that's the traditional welfare check,
Right.
but is that the best welfare check?
No, it's not.
And so we could conceivably, I mean, it's beyond the scope really of what we're talking about here, but that could be a role for community paramedics.
Right. But if there's not community paramedicine available, and then it comes down to resources. What are your resources within the community? A lot of these communities don't have those resources, and they don't have the budget for a lot of that resource. And so they're utilizing those first responders as that type. And so if the system went into place, it would be, over the course, you're talking about full state of Washington, and you're talking about very small environments that have little to no resources that have to go to bigger towns to get those resources, Spokane being one of them, Seattle. I know that there's people from Tri-Cities that goes to Portland, Seattle, or Spokane to get services because they're not available.
That's one of the really nice parts about the system is it really is the framework and the technology behind it is infinitely flexible. It's really about what the community decides they want, what services they want to connect up to the natural community of care.
Okay.
So there's not
I needed.
there's not somebody telling you how it needs to be. You have to get together with the agencies in your community and decide what those relationships look like.
Yeah, the technology, as Adam said, is infinitely malleable, so it can be configured in all sorts of different ways. It really goes into what the community wants to do to care for that population. What we ran into in Clallam had to do with folks that do substance use disorder counseling and the regulatory framework around 42 CFR.
Mm-hmm.
And so the proximity of law enforcement, and I mean, I ended up reading a tremendous amount about this and kind of just how those offices used to be rated as part of drug raids. And so there is a lot of history behind how we ended up with that regulatory framework. And
how close are they to go live?
The software is built, and we're now in the HITRUST network, and we've secured the communication between the EHRs and things. So right now, they could go live if they wanted to with it. But, and we have business associate agreements between all the parties and so forth. So we're actually okay to exchange information. The community said we're not going to go live on this until we get the data policy completed. So the technologically we're there, but the policy framework. So, because in essence, and I think the question was asked in the previous meeting, is just saying, because the other part the community wants to make sure of, which is every community is going to have to think about this really carefully. This is kind of like a public utility. So how do you keep the utility running? So it's, you know, this is a capability, but, you know, and the ACHs have been wonderful to kind of kick it off, but the communities have to figure out in this natural community of care format, do they have a mechanism between value-based payments and things like that to sustain it? So these are still open questions that have to be, you know, for groups that want to do this, they're going to have to make sure that they're comfortable and clear about how that would work. But, you know, at least the technology barriers are pretty low. It's the other things that have to be really thought through.
And we're hoping that once the program is put into place and in implementation and it's functioning well, there'll be enough of proof of concept to roll it out to payers and get that support. I mean, I think this is potentially equally as good as the hub model. I just wanted to point something out. In the selection process, we put an RFP out to select Rob. One or two other vendors did put forward a proposal, but to be honest, it was geared more towards what Rob was doing based on what Elliot told us. After that, we created an application and went through an RFP process that actually selected GCACH. We intentionally selected it out to 4 different areas across the state. 2 responded, and GCACH is the one that was selected to unroll this pilot project.
So just in the interest of time, let me see if there are any outstanding questions from the board. Any burning comments that any of our presenters are dying to not leave left?
Thank you for driving down today. We really appreciate it.
Left, I'm sorry.
So you define community, and these systems in an urban setting would be functioning, but you know, how is Patterson involved, or Starbucks, or you know, these communities that are either there's a small community and there's a lot of industry that's spread out that makes that into a community, or they're just a long way away from everything. I mean, Colotus is a long ways away from everything. So how do we then, I mean, I know we have to start somewhere, but how do we then stretch out and include some of these other communities?
That's a great question for Carol and Wes.
We're going to be talking about that in a bit.
Okay. So can you hold that thought? I think that's Carol's.
It's all right.
Okay.
Well, is going to have to deal with that with Forks.
Yeah.
And with the same kind of view or framework. So.
Okay.
Yeah, I know in Olympic they're looking at options like virtual visits and things like that. So
and that is
Telecare,
and that's really great attributes of this particular system. So whether we send a referral for transportation or we send a specialty consult, it's the technology can really be configured in all those different ways. And a friend of mine runs the University of Washington telehealth program, and so he's been tracking this really closely. He'd love to serve if you're interested. So each community has to decide what's in the way they want to do it.
We may be contacting him.
Because one other thing that's exciting we didn't mention is the opportunity to work across communities. So because we're kind of banding together under this umbrella of the Health Commons Project, the hope is that, you know, what we're working on in South King and what Ellie and team are working on in Olympic and what you all are working on here is shared across boundaries, so that both best ideas are shared and the costs of running the network are shared to make it affordable.
Yeah, the goal is to make it very, very low cost. So, you know, it's being developed under that model. So, you know, we know cost long term is going to be really, really important. So we want to make sure the capacity is there at a very low cost.
Okay. Well, thank you all for driving over the mountains, and Dr. Martin for driving a little bit over the hill. Appreciate your all being here. Very helpful information.
Thank you, Rob. Thanks, Adam.
Thank you.
Thank you, guys.
Thanks, Kevin.
Appreciate you guys coming out.
My drive was much shorter than COVID.
Before we leave the topic of care coordination, Carol and I had a conversation earlier this week, somewhere, about the sustainability topic, and one of the things that we do know is within the Medicaid system there are coordination of care fees, and I know within our organization with the state Medicaid agency and some of the plans there are codes, for example, in our medical respite program we've negotiated reimbursement, but there are other care coordination fees that maybe at some point that we should get together with the other ACHs to be able to talk about embedding those into our state Medicaid plan. Because whatever tool we use and however we do care coordination, that is a potential for sustainability. So again, I'm showing, just as I always use aging and long-term care and the health home program as the model, because they were able to show the return on investment through the health home program. And I think we all believe that care coordination is going to be an important part of this. And so those tools exist, those fee schedules exist, and so it's something that we should collectively all be able to go to the state with and show the return on that. So I just throw that out there.
And I do think that Emily Winkler was going to join us. It's on the line if you wanted to transition right to that, Rhonda.
If that works. If Emily, are you with us?
I am here.
So let's go ahead and do that. Does that work for you?
Was that your
Well, I
question?
just had a clarifying question. Maybe if I ask that, she can fold it into.
Okay.
So when we talk about care coordination, one of the challenges I think that some of us who've been doing community-based behavioral health care have is we've been using community support to do a lot of these functions. So there's this kind of gray area of overlap where we might have somebody who's working with somebody on their diagnosis code of schizophrenia who's doing community support because their symptom interference doesn't allow them to engage with their healthcare provider. So their plan of care includes transportation to medical appointments, coordination of services between medical providers, and it's covered under the Medicaid plan with that label. And so we have a number of activities that I think there's overlap, that it gets a little bit confusing about when we start talking about care coordination and we're hearing like activities. Are we talking about a system change to redefine, or are we going to leave the overlap in place, recognizing that different patient populations have different levels of care coordination needs? Because all that seems like a black box to me right now that's hard to get a confident feeling about how we contribute or how we offer our services and not be either duplicating or leaving a gap in the system.
I think the question is it a black box or a black hole?
Could be both.
And we did talk actually at the Leadership Council a little bit about that in terms of how we all use the term and how we define what care coordination is. And I think that is something that needs to be answered. I'm not sure anybody has that answer yet. So Emily, why don't you go ahead and open this up for us?
Sure. So I just, really quick, my goal here is to present to you the inception of health homes to where we are presently. Is that kind of what everyone in the room is looking for?
It was an example of how a pilot program around care coordination came into fruition and the steps that were taken.
Sure. Okay. So the health home model started out of Section 2703 of the Affordable Care Act. And Washington State did they have a SPA, state plan amendment with CMS, and they began with two strategies. So the idea was going to be to compare and contrast a fee-for-service model and then a fully capitated model. So the fully capitated model was going to take long-term supports and services, medical services, their health home services, and bundle them all together in a capitated rate with one provider. They started rolling out the fee-for-service strategy, which is that none of the services change for a person, that health home is just an additional service that sits on top. They rolled those out in July of 2013 in Pierce and in Southeast, which is Area 7, which is your area minus Whitman County. And basically, the state was never able to negotiate with a provider in King and Snow for the capitated rate. So they went back to CMS because of the success of the fee-for-service program and asked if they could just expand the single strategy across the entire state. And they agreed to that, and King and Snow, Snohomish counties started rolling out health home just in January of 2018. So the whole entire state of Washington now has health homes available. When you talk about the demonstration project, we're talking about a select portion of the population. We're talking only about the duals who are in a fee-for-service model, or there are a few Medicaid populations that stay in a fee-for-service model. Native American, Alaska Native, they can choose to opt out of Apple Health and stay in a fee-for-service model. The state of Washington did, though, want to apply the entire project to their population. So actually, Apple Health managed care entities are to offer health homes as a service in their suite of services. So any client who is a full Medicaid or a full dual is financially eligible to receive health home services in Washington state. When we talk about the demonstration and we talk about the cost savings and the money earned, we're only talking about the dual fee-for-service population. They have not done studies on the straight Medicaid clients as to yet. So the state worked with CMS to identify people that they would have eligible. So they have to have a chronic condition. It is all ages, so it is birth to end of life. The population that they selected is statistically higher utilizers for emergency department hospitalization or rehospitalization. And then they needed to have a risk score of 1.5 or greater in the Predictive Risk Intelligence System, or what is commonly called PRISM, that the state of Washington created. So PRISM, that's one of the things I want to clarify about it, is PRISM goes out every 2 weeks, and it looks at every Medicaid user, and it identifies a typical user and sets that person's risk score as 1. It then compares every other person to this fake identified risk score of 1 person, and it scores them against that average user. It only looks at their age, gender, diagnoses, and their medications. It does not look at spending. It just looks at those 4 factors and compares that person to the average user. The idea between the score of 1.5 is that they are at risk of utilizing 150% more resources than the average user. So for the dual population, that's about the top 7% of the population. They have a risk score of 1.5 or greater. Your risk score for a client is not going to change. It's not an item that we track or that we use as a success trigger for the model, because as you age, your risk score actually goes up, so you can't change age. Gender, women are slightly higher risk scores than men. And then if it's a chronic diagnosis, it's not going to go away. But medication changes can lift or reduce your risk score. So once a person risks at 1.5, they're actually eligible for the program for the rest of their time on Medicaid, Medicare services. So why did they focus on care coordination, especially in the duals? There is a overlap in delivery systems between the population, a high overlap. So one of the slides that they always show us is that 78% of people receiving long-term care supports and services or developmental disability services. So that's in-home program, assisted living, adult family home, or skilled nursing facility. 78% of those people score into the 1.5 or greater. Additionally, 55% have a serious mental health illness that's being treated, and then in the elders, only 7% with drug and alcohol treatment services. In the dual disabled, the younger group, it's 47% are utilizing long-term supports and services, 67 are being treated for serious mental health illness, and 27% have drug and alcohol treatment services. So definitely between those three types of services, there is a overlap in clientele. So what are the health home services? There's 6 services. They kind of blend. Comprehensive care management. So that's when we establish person-centered health action goals. So the program uses a health action plan. We develop a long-term goal with the client that the client is interested in and motivated to work towards. We then work with the client through motivational interviewing and goal setting practices to develop short-term goals. And then from those 1 or 2 short-term goals, then we develop action steps. So it's a face-to-face interaction, high touch. So the clients are seen at least monthly, and they work with them through those action steps and have you completed it? If not, why? What do you feel we could troubleshoot to do that? And help them work through some of the barriers that might be keeping them from meeting their goals. The goals don't have to be health related, but you often find that if someone has an item that they're motivated towards and want to complete, or I want to go back to school, I want to see my grandkids play soccer, you find that as you work back from that, you're going to get a health-related goal that they're going to need to work on so that they can establish that long-term goal. So the idea is to engage them at their interests, and the health improvement will come along behind that. So comprehensive care management is to establish the person-centered goals. There are also a few required screenings that the Healthcare Authority requires absolutely to be done. So the program uses the Patient Activation Measure, or the PAM. I don't know if you're familiar with that. It's a 13-question survey that is evidence-based, and it's shown that it can measure someone's activation, give you an idea of where they're at in their health engagement so that you can target resources towards their engagement level, and that as you increase activation level, there is a direct correlation in decreasing, that you see in a decrease of healthcare costs. We collect BMI. We do the PHQ-9 for depression, the CATS ADL screen, so activities of daily living. And then for kiddos under 17, they do a pediatric symptom checklist 17. There are also a couple, like what they call optional screenings, but stay consistent throughout. For pain, they use the FLAC, numeric, or Wong-Baker faces screening. The GAD-7, so generalized anxiety disorder. The audit, so for alcohol use, My Falls Free Plan, and then the DAST, which is a drug abuse screening. Those ones are optional, but get used when perhaps someone has a diagnosis that would trigger needing to, measure and screen those items. Care coordination is the next service, and it is the the big component of the program. And I kind of heard you guys talking earlier about it's interesting to hear how different people define care coordination and what it is and who can do it and what type of setting. Care coordination for Health Home is coordination across the full continuum of services and settings. So what is nice about the Health Home program that's different from some of the other programs is that we can follow a client regardless of the change in their location. So if they're in home and they transfer to a nursing facility, and then from a nursing facility need to come to a adult family home upon discharge, that same care coordinator gets to remain with them across that continuum. And then the hope and the idea is that the care coordinator works with them and does the same type of bridging between care provider or healthcare providers. So primary care, often one, if not two specialists, their pharmacy. The care coordinator is to be the thread that weaves between all those systems and works to keep everyone on the same page. All while modeling for the client how to do those types of things for themselves. So with care coordination, we go to visits. We go to healthcare provider visits with the client. We can model role play, working with your physician, advocating for yourself. It's kind of the bread and butter of the Health Home program. The health promotion, disease prevention, so providing education based on the client's level of engagement that comes off the PAM. And when possible, to engage in evidence-based healthcare services. Comprehensive transitional care is included. They do not require care coordinators to be trained in an evidence-based modality, but the state has developed what they see care transitions as. And so it is medication review upon discharge, getting them, ensuring that they have follow-up with their primary care provider, working with them on their discharge paperwork and their understanding of it and their ability to follow through. Individual family and support is an additional one. So often we can work with family regarding whatever it is that they might need assistance with dealing with their loved one's diagnosis. We do referrals to various different programs, such as family caregiver support. And so sometimes if the client isn't fully able to participate in their care, we can still enroll and work with them in health homes if they have an informal or family support that would like to participate. And then the last one is just the catch-all of referrals to community and social support services. So working on housing, food bank referrals, following up on, DME and how they're getting it and any barriers to that. As far as who provides care coordination services, there is a long list of educational eligibility, but mainly what we see people using are bachelor prepared social workers or affiliated degrees with 2 years experience, and then registered nurses. You can have licensed mental health, affiliated mental health if the organization providing it is a mental health agency. chemical dependency providers. So it's quite a broad swath of who can be a care coordinator. There are some big changes coming to Health Home with integrated managed care rolling out, particularly in Area 7. Optum was a fee-for-service dual lead across the state, but with the BHO I'm speaking on lightly what I don't know, but being absorbed into the MCOs, Optum is no longer, has given back their contracts to provide health home services. So Southeast Washington Aging and Long-Term Care will be the only community-based lead in Area 7. In Whitman County, actually have several community-based leads in Whitman County, or not community-based, but fee-for-service leads. But up there, it's Community Choice is the name of the community-based lead in Whitman County. The other big change for Area 7, but it also then, I do believe they made these match the ACH, is that United Healthcare was not a successful applicant for Apple Health, and United Healthcare will be pulling their presence from our area December 31st. So we will still have Community Health Plan of Washington, Coordinated Care, Molina as managed care entities, and then AmeriGroup, 4, there's 4. And then
Sorry, I just happened to be sitting right here.
That's okay. I was like, wait a second. I know there's one more.
Yeah.
And I always have to try to count. And then Southeast, just in a dual fee-for-service capacity. And at this point in time, United is stating that they're staying as a dual fee-for-service capacity.
Yep.
So those are your players. So then here's where it gets messy, is there's a coverage area, and so what will we have now? We'll have 6 lead entities in the coverage area. Clients funnel down to those lead entities, and then they funnel down to care coordinators. Multiple care coordination organizations are contracted with multiple lead entities. And so there's a lot of like cross-wiring, cross-systems for the care coordination organizations, because we're all similar as leads, but there definitely is a variation. There definitely is a variation between a managed care lead and a dual fee-for-service lead. Our contracts are a tad different and different arena. So that has been probably the biggest barrier for health homes from its inception, has been the lack of a single platform. And then there has been a lot of concern over the rates and sustainability. As of July 1st, there was a 20% increase in the payment to the rates for the duals demonstration program. The duals demonstration program, in its first 3 quarters, had saved $64 million, half of which comes back to the state of Washington in a shared savings contract with CMS. They do some really crazy statistical determination to figure that out. They take our entire population and compare it to state with a similar population. A lot of actuary statistics that I don't even start to understand. But at this time, the duals portion of the health home program is fully sustaining itself and bringing money back into Washington state. So benefits so far is they are seeing an increase in patient engagement screening scores. There is been formalized agreements between community partners who have always been community partners, but maybe perhaps never before had a formalized agreement. So that's opened the door to a lot additional data sharing, client sharing, knowing what each other does. CMS has done a report on the success of the Health Home Demonstration Project in Washington State. Health Homes is in various other states. We are one of the successful ones. And I was off. It's not the first 3 quarters. It has to have been the first 6 quarters. Is the 64.5 million is what rings in my head as far as shared savings. So that is a really big overview of Health Homes. I hope that's what you were looking for.
So thank you, Emily. This is Rhonda. At a high level, can you describe what the shared savings program, so the state has an agreement with you to share some of that savings back, and you share some of that back to the providers. Can you, at a high level, kind of describe what that looks like and how that works?
Yeah, sure. So, well, it's changed. You're talking about the incentive payment. So the CMS and the state have certain measures that the state has to reach. And so what the healthcare authority, I'm used to calling everyone the state because we contract with DSHS, so we contract with the healthcare authority for health homes. They roll some of those measures down to the lead entities as performance measures. And then based on your performance, they provide you a performance enhancement payment. So prior to the increase in rates in July, it was a 20% performance enhancement payment based on what they call your engagement rate. So that's the number of people that are actively engaged and participating in health homes. So what they will do now is they're going to take July, August, and September for Southeast, for example, and we have to hit an engagement rate of 30%. So 30% of the population assigned to us has to have had an encounter during the 3rd month of the quarter. So they only look at the 3rd month of the quarter. If we hit that 30%, then they take the amount of money that we build in each month and times it by 5% and hand us a check for 5% of that money. We are allowed to take a 10% administrative fee off of that as a lead. And then what we as a lead do is that we take the number of encounters, regardless of what type, because each encounter weights equally for us in the numerator. And we divide that payment by the total number of encounters. We get a per encounter rate, and we pay our CCO the rate times the number of encounters they had in the performance month.
Okay. Other questions? That was a really good overview, by the way.
Yeah,
Thank you for a detailed program. Great
Thank
job
you.
on that. And she had, like 4 hours notice for this? Do people have questions about that model? Dan, you look like you do.
Yeah. In terms of the individuals doing the care coordination, you kind of painted this broad swath or brush of who is actually doing the work. Are there enough people doing the work?
Network capacity has been an issue. There have been a lot of jobs created, and we are finding recruitment more and more difficult. I can only speak to Area 7, but in like Yakima and Benton Franklin counties, we're seeing that across all of our programs, not just Health Home. the healthcare authority is trying to develop and work on a model of how and when it would be appropriate to use allied staff, but that is not really at a level that
You mean
they
allied
haven't come to a lot of agreements. Excuse me?
You mean allied healthcare staff?
Yeah, community health workers. That they would do a portion of it, portion of the care coordination with oversight by a care coordinator. I don't think, we're waiting for the proof and the numbers on it. There's a couple places that have trialed it, but to see if the salary of that allied health person offsets or is offset by the amount of caseload you can increase with a care coordinator is yet to be determined. So I guess the long short is no. Capacity is always an issue. There have been care coordination organizations that, rolled out in the beginning and due to the rate just couldn't sustain and didn't want to continue with the program. There are care coordination potential people who are, nervous to start the program. I do believe, though, that the 20% rate increase is going to help with the ability to build network and build capacity.
Ed.
So, Emily, this is Ed with Comprehensive, and worked a lot with Pasco office and stuff. So we've had a couple different, in Pasco we have 5 workers, and we're able to recruit fairly easily, and we use bachelor's level to have a healthcare degree with 2 years experience. And in that site, it's because of the program's success in helping people, we're actually, when we're losing staff, it's to go on to graduate school and to grow professionally. So that's a good way to lose people. We also have people outstationed in Chelan, Douglas, Grant counties, Kittitas, and there it's a real recruitment problem of getting people who want to do the work and who are working remotely from the main office. So there's really a blend of reasons that I didn't want it to feel all negative, because I'm actually kind of happy for the folks who are coming through in the Pasco site, who they come and they work for a year and they're excited and they decide they want to be an MSW and they go off to go to school.
Right.
So
and I didn't mean for it to be negative. It's the growth. We're sustaining the people. We're growing. We're adding positions.
And this is a model that's primarily, it isn't just based in behavioral health, it's also based in primary care, correct? With those.
Yes, so care coordination organizations, mental health, chemical dependency, federally qualified health clinics, the area agencies on aging, the hospital district for me in Columbia County. So yeah, it's a blend of both.
So this is Rhonda again. We have 12 care coordinators, and we've actually had very good longevity with our group. And we've been growing just because we've been able to add cases. And we work with all of the plans on aging and long-term care, and the majority of our staff are BSWs. And we have had actually a couple that have gone on that are working on their MSWs, but they're doing that while they're still continuing to work. And so, I mean, that's actually a great success story for us too. We feel good about that. But
so I'm hearing care coordination.
Yes.
Population difference. Is that what the issue is?
Not significantly. Ed's population are serious mental health.
Not always, because we're contracted through aging long-term care, and so they're not. These aren't our mental health case managers. Okay. These are care coordinators hired specifically to serve the high PRISM score risk population that they're contracted. Okay.
And what I would say is that we could provide care coordination for a lot more people it's a very specific population that qualify for health home, but there's a lot more people that need care coordination that
Right.
we're able to qualify because, you get them, either the state deems them eligible, but they also allow a mechanism that says, if you think somebody needs it, you can screen them to see if they can qualify. And we are only, there are very few that we screen that we can make eligible. If the state hasn't identified them, it's really hard, at least for us, it's been really hard to screen somebody into the program.
So, it's not just mental health that care coordination comes in. I'm a recipient of Apple Health through disability, and so I'm at United Healthcare. They're my coverage, and so I get a phone call quite frequently from my care coordinator. And she wants to know what I've done, where I'm at. Do I know that I have this? GCACH is my clinic. I go there all the time. I get great care. They do my referrals, whatever it is I need. And they really saved my life. But if it wasn't for that element and me having that ability to have that care coordination, my medical care would have been down in the dumps and I would not be sitting here with you guys today. So care coordination is definitely a serious piece of staying healthy when you have multiple health challenges. So they do medical, they do mental health as well. With me being peer support affiliated, I can be a care coordinator. It's a matter of what kind of care coordination. So in our agency, the care coordination is across systems, but it stops at the mental health. It doesn't cross over to medical health. So they're not coordinating anything medical. They leave that up to the doctors and the facilities that they're going to enter into for services. That's where a secondary care coordination needs to pick up right now. But if you had a care coordinator that would go across systems, it would be more efficient and more appropriate. Yes.
I believe in January that the managed health coordinator, remind me if this is wrong, but the MCOs with their care coordination for behavioral health will start in January. Is that correct?
IMC would hopefully help with that.
Yeah. Since they're going into managed care. Yeah. So in January it'll be all one.
Okay.
So I guess, Carol, just to help us move along, do you want to maybe talk about, or are you prepared to maybe talk about why we're introducing or starting this and kind of where we're maybe the next steps would be?
So the document that Lauren is showing on the screen is really just to tee up this conversation so that we have gone down the road. We're doing integrated managed care with our behavioral health providers. We're doing PCMH with our primary care and those behavioral health organizations that want to bring in primary care, vice versa. But we haven't addressed how we formalize care coordination. So one of the ideas that Rodney had was, well, let's hear from a successful example of how that could work. I think the extent to which that program is so evidence-based and has so many tentacles into all of these different assessments and scientific ways to measure a person's health just, speaks to the fidelity of the program. But we also know that there's lower levels of care coordination that need to happen that might not need that level of fidelity. But that we have partners, such as our community paramedicine partners, that can go into the home. And we heard Kevin this morning say that, the key to success of a transition program is having somebody go out to the home within that 72-hour period, right? So this is just the opportunity then. Let's tee up, talk about care coordination, because it's not necessarily reimbursed, depending on what level of care coordination that we're talking about and how do we pay for that as a board. I don't know that we had that analysis available, Becky, but I think the most recent analysis showed that even after we pay out our population health management funding, our QI teams, our PCMH assessments, yada, yada, there's about approximately $2 million left in 2017 funds that we could distribute to our care coordinators. So the idea is, could we use some of that funding then to have pilots of certain kind of care coordination, to show our MCOs in the future that this really does pay off to have this kind of care coordinated, and perhaps, as ACH is working across the state, we're all looking and thinking about this, and Caitlin and Kat can speak to this, but how do we make this a sustainable program? In talking with Ben Shear this morning, he's with the Pasco Fire Department. They're very interested in providing more at-home services. So I think that there's ways to save the city's money. There's ways to save our providers a heartache, around the conditions of a patient when they come to the emergency department and they have no recollection or no idea of what this person is facing. So this is just an opportunity to open up the dialogue. The Practice Transformation Work Group talked about this last month, but didn't have any real recommendations of how to bring this forward to the board of directors. But we do have funding. We do have this need to do care coordination. So how do we do that? So this paper simply I borrowed from a book that that Wes had in his office. These aren't any ideas from me, but in terms of the background section, it really is related to, how do you do care coordination effectively, knowing that we have patient-centered medical homes as our care model, but primary care might not always be in the center of that person's care if they're approaching it from a different door. So I just do recall that in the behavioral health group, that was one of the tenets, is that we're trying to create this no wrong door model of care. So we just want to make sure that that patients are falling through the cracks.
I just have one question with it. So as an organization, we're already under contract with the MCOs to do care management. And it's a little different for each organization.
Right.
But it almost sounds, and I'm just not connected yet, so it almost sounds like we're duplicating or we're reinventing a process that they already contracted purchase for. And it doesn't sound aligned with, you're trying to create a project they want to purchase, but they're already purchasing it. So I'm wondering if you can connect the dots for me.
So I think for providers that are traditional Medicaid providers, either VH or medical, we can easily contract with you and through our medical payment to you, which will soon be an integrated payment. Stop saying medical payment. We can include things like a care management, PMPM, that's usually what it is. And that it can be incorporated in an overall value-based model that you have, which can be sort of allocated specifically out of our medical budget. Sometimes it comes from our admin, but to contract with a specific social service entity that does not do Medicaid services, like health services, we have to pay for that out of our admin dollars, can't be a medical spend. So it limits, and plus it's complicated sometimes for those entities contract with us and bill for services that don't actually have any sort of coding related to them, and set up all those processes. It's sometimes not worth it for the entity, less so with us. So I think that is my understanding is where we're trying to get to, so that if there is somewhere you want to refer to from a community group, that community group has enough capacity to actually take the referral and do something with it. Whether or not, I think something, and Kat, please, once I'm explain this next part, please jump into. One of the things that especially Kat and I have been talking about in other regions is, as we move to value-based payment, our hope would be that through the risk that we're passing on to providers, that you would be incentivized to coordinate with the community-based organizations to provide these other services, and you would be the one starting to use your sort of admin dollars that's incorporated in your PMPM that you get from us to pay for that. But that's not possible for everybody.
So in the way that we work now, as I understand it, so you as an entity identify your covered lives that represent the higher risk, and you send a referral list out to us on a monthly basis. We do the outreach, and like Rodney was saying, it's a benefit, and a lot of people we're finding are mistrustful because we call them and say, hi, you have this benefit. Oh, leave me away, telemarketer, and hang out. Yeah. But so we're trying to really get a targeted population to have that impact.
Mhm.
And so if we're looking at organizations that aren't necessarily providers already, or medical or behavioral health providers, then are you thinking like transportation, you close
Yeah.
the transportation gap, or?
Or at the moment, since we don't have, unless you're part of the FCS program, supportive housing services, that's another example. Or even just finding housing. That's a care coordination thing that it's involved with care coordination services, but if it's done by a community organization and not by the medical organization, that's hard for them to get reimbursement for directly from us.
I get that.
Yeah.
Yeah, so basically, any of the social services that need to be pulled together, you gotta have them done outside of the MCO, but you gotta find a way to pay for it in the middle. Yeah, I understand that. That was actually what my question was how do you pay for it?
Rhonda, I have a question. I think you mentioned earlier that there's a component of your patient population that doesn't qualify.
For health homes, yeah.
And so it seems to me that would be your pain point.
Yeah.
Well,
whereas you would identify that group.
2 points. Yes. Thank you for that. But also go back to what Emily said. Our goal in Health Home is to reach 30%, is to engage 30% of the people who qualify. There's 70% of the people that are eligible that we're not engaging.
Right.
I mean, it's a hard sell, going back to what Ed just said. It's a hard sell to engage those patients. And the people that fall just under 1.5 there's not a lot of need difference to those that are above. And, in our program, I mean, we give our providers a little bit of latitude that says even though they don't qualify, we'll give every care coordinator 2 or 3 or 4, patients that they need to care coordinate, even though we don't get paid for it, because we've got some patients that just have high need, and plus we have this other homeless population that are not going to do anything without that. So but the other point that I would make to Ed's comment is, even though care management is part of what we do, care coordination still costs extra money. And so, I mean, because there are typically multiple specialists involved in addition to the social determinants, and I would say, I don't think we're unique. Probably 70% of the work that our care coordinators do are about social determinants. It is housing and food and all of those, and transportation. So, I think that sort of where we started is the idea of piloting something, but with the end goal of proving the ROI so that we can build on sustainability, whether it's through the state, because the MCOs aren't going to do it forever unless we can assure that the state's going to be there to back them up. So.
And that's part of the conversation we keep having with the state about pathways as well, from an infrastructure standpoint. But I do think in the pathways discussion, this is less about the platform and model, more about the population. One of the ones that's come up the most is the pre-health homes population, because those are the ones that the health homes population is like the 5% high utilizers that do cost us the most amount of money, but there is like a good 10 to 20% of people that also cost us a lot of money in the system. And it's trying to identify those. And I think we all struggle with making sure that they can get targeted, but at the same time, how do we connect it to health homes to get engagement rates up? Because 30% is an ambitious.
It's ambitious, that's right.
Yes, like most regions, this region's different, and so is the one in Wenatchee, but most regions have low engagement rates.
Well, it's a voluntary program.
Right, exactly.
So by low, do you mean like 2% or?
No, it's not like
18?
that low. It used to be, the whole point was the engagement rate for these clients used to be like 2 to 5%.
Right.
So Health Homes has helped now, it's between like 10 and 17, I think, depending.
And our region is what?
Can I just interject for a second?
Yeah.
This is Emily. You're mixing the populations. So the Medicaid engagement rate is between 10 to 12%.
Yeah,
the dual engagement rate is higher, 25 to 27.
And that's why the duals have saved money, and it's on the Medicare side.
Right.
It actually hasn't saved any money on Medicaid yet.
Well,
But that's also because they haven't done the analysis fully on Medicaid. There's a whole bunch of issues with that. So it's not, we don't know.
Right, and Medicare is their primary payer.
Yeah. Thanks, Emily.
So back to what
Carol was asking about and doing a pilot project, you're going to have some challenges around that because of pay, but also from experience, you're going to also have challenges of succeeding in action steps that you would have for these people coming in. And the reason why is because you're going over, it's not just into care services, you're talking about housing, transportation, and that. And in my experience, there's no place for people to get bus tickets unless they're capable of paying for them. And I'm sorry that everybody that's on the lower end of that spectrum is not going to be able to afford a monthly bus pass.
They have they have a program that they can utilize through transportation through Healthcare Authority. So they're
Okay, I would like that information, please, because I have a lot of people that are still looking for that. Yesterday, I had someone come into my office because they couldn't get into housing because Kamayakan Apartments decided after a year that they were going to sue them and say that they didn't, that they left their apartment in damage and is charging them $1,300 in damages. And they had lived in the apartment. They got a letter that stated that they left the premises in good standing order, but yet now they're sent over to a collection agency and now they can't get housing because of the criteria that you have to meet under those housing applications. The other things that are going to come in is how much housing is here. We're at 93, I think, % capacity. So housing is difficult. They're building a new building over there. It's not going to accommodate what we have in homelessness.
So we're getting a little bit off track here.
So what I'm saying is care coordination, being paid for it, and doing what I was doing and trying to get licenses so that I can continue what I was doing in outreach.
I understand.
There's nobody that's going to pay you for it, and there's nobody that's going to come in kind services with you on it, because there's transportation that I gave. There's all these things that are just multiple of
I would agree. Every community is going to have some unique challenges, but
Right.
we can't let that stop.
Well, I understand that.
I wonder if it's a navigation opportunity too.
Yeah, yeah. And, usually, I know in our community, the people that, like Ronnie, that have their boot, that are
Right.
on the ground are the ones that usually figure that out better than anybody.
Yeah, no, absolutely.
Yeah. Okay, so
I just wanted to point out, and I'm glad to point out, so the analysis is that Wes did this analysis of the CSA, and so we have a list of all of the organizations that were appeared multiple times in the community, or the current state assessment, and they're listed there. And then there were some 1 or 2 off, and you'll see that I kind of grouped them in terms of schools or social services or EMS. You can kind of scroll down there, Lauren. So you've got definite partners that are non-traditional Medicaid providers. And then we also had a section, you might recall when we did the scoring for the PCMH organizations, we called them healthcare partners because they do care coordination, but they don't provide primary care services. So you can see the number of times that they came up, and then the actual scores that we assigned to them with Southeast Washington Aging and Long-Term Care, Signal Health, Consistent Care, Chaplaincy Health Care, Sundown Ranch System Treatment Services, all the way down to your health district. So we know that there are strong partners in our region that we should be probably connecting with. We just haven't had a good discussion on how do we do that formally. And I guess this is kind of that one piece of PCMH that Patrick reminded me yesterday or a couple of days ago, is that this is the tough nut to crack, is that this is what we haven't been able to crack necessarily with the PCMH model, but this is our chance to be innovative and to try something new. I don't know, Patrick, if you wanted to give us any of the history of that, but.
Nationally, I think the dilemma facing a lot of PCMH models has been, how do you allocate the shared savings, even if you can calculate the shared savings? How do you allocate them on the basis of what?
Okay, well, this is an initial conversation, food for thought, and we'll probably talk about this again next month.
So do we have any ideas? I mean, is there any sense that we can get from the board as we're approaching our implementation?
Well, let's just start, I guess, from the big picture. The idea of piloting something, is that a thumbs up from people.
Yes, yeah.
So maybe, it's usually easier to react to something. Do we want to maybe just have a special session of anybody that's interested in brainstorming? I'm kind of mindful of the time and what we have to get through today, but how would you like to?
My only encouragement this time, I agree with that idea, it's a good idea, would be to, instead of doing an RFP, is to, from the brainstorming, set your goals and what you hope to achieve, and do it as an RFQ, so that you're buying something you've already picked, not asking for a rainbow of proposals that may or may not touch on what you want. Make it a very narrow, focused process and select qualified applicants based on your goals and the metrics that you build into it yourself, so you know what you're trying to achieve and can measure it without counting on somebody inventing that part for you.
That's a good idea.
Okay. So we can, any of you that are interested, I'll be reaching out to see if we can put together an RFP process.
And I think it would be great if we could have either Emily or somebody from Aging and Long-Term Care, because of their experience, and maybe some of the MCO reps that have been involved in health homes. It would be helpful.
And maybe even reach out to, so that in our region, the broker for transportation is People for People.
Yep.
And ask them to come to the table, and then if we could get a representative from the Landlords Association in the area we're looking at, because a lot of them were drawn in under that 2163 and 2060, the Affordable Housing and Homeless Prevention. A lot of them were told by Commerce, come and form these registries so that we can get some of this funding back out to you. And I don't know that we ever really fully engaged the landlord workforce or landlord.
Well, we have relationships with the landlords. That's because we're the housing broker. We do a lot of the contracts with them.
Is that the same thing as the housing authority?
No, they're separate.
It's the Landlord Association. But just when you select in your target area, they might be folks to include too. If we can include as many of those people who manage factors from the social determinants of targeting.
There might be some specific landlords that we'd want to engage that would be helpful.
Leaders, yeah.
Okay. Sounds good.
Okay.
Perfect. Thank you.
Great conversation.
Thank
you, Emily. Okay, so should we back up to the, so this was the partner funding SFAR, or is there another one?
No, that was
That was
House Assistant Clinical Community Linkages discussion. Way down there.
Okay, so do we have another one then?
So I guess that was the CDO and partner funding SFAR.
Yeah, that's what I thought.
Okay.
Okay, so I think we're back to the financial statement.
Yes, and I think everybody can read your own report, right?
Okay. So Becky.
Yes, I'll make it quick.
Okay, appreciate that.
Okay, so first thing is the balance sheet. Lauren, get that up.
Sorry, I'm trying to find which one it is.
Statement of financial.
Yeah, statement of financial.
There you go.
So, there's not really anything on here that's anything new. I'll just kind of skip this, if that's okay with you, Rhonda.
I think Brian's here, so ask if it's okay with Brian.
It's okay with Brian.
I second Brian's motion.
Okay, so.
I think we had actually sort of prepped a motion coming out of the Finance Committee, correct?
We did.
Yeah.
Do you want to just skip right on to that?
Yeah, you're fine.
Okay. So, Brian just said the funding allocation recommendation in the Budget and Funds Full Committee is, but we're going to skip to that one, sorry. So that's the engagement fund.
This one.
Yeah.
Mm-hmm.
Thank you. So this is kind of our little budget that you guys have seen before. But the question that we had for the board is, you can see the PCW membership, and we have the PCMH, QIT, base population, base practice.
So, I'm sorry, Becky. Can people on the phone hear Becky?
Yes.
I think the comments will just into the table.
Okay, do you want to maybe come down here?
Yep. I can them down here? Or I can just show you on here. So this is what we're talking about, all these,
They want
line
to turn the
items with
microphone.
the zeros.
They want to turn the microphone.
Okay.
Yeah.
So and Brian, you can chime in if you want.
Okay.
These are the things on this report that we are ready to fund with the practice transformation group. Our navigators have been going out and working with our providers for specifically the MEHAF and the Bulletin Toolkit, two things that I think they've been really working hard on. And so we're ready to fund those things. And so we've put some allocations on here that has gone through the budget and funds flow, it's gone through the finance committee, and we're ready to bring it to you guys for your approval.
So specifically, those would be the practice transformation work group membership, the MEHAF, PCMH,
QI team, base population health funds, and the base practice transformation funding.
Right. So what you need is we need a motion. Are you looking to move on the 254? Is that the number?
These numbers.
I see.
Yeah. So we're looking for a motion to move on the amount per organization column here, where we've allocated the amounts that we want to pay the providers for these things. So $15,000 for the PCW membership, $10,000 for the MEHAF, $10,000 for the PCMHA, $15,000 for the QI team, $40,000 for the base population health funds, which includes a lot of things. Direct messaging, the risk stratification and disease registry, and then the base practice transformation funding for $100,000. So that's what we're asking for, is that you agree with the money that we've decided to allocate for those items.
And these are recommendations that came from the Budget and Funds Flow Committee?
Yes, they've been through the budget and
Yeah.
funds, so they've been through the finance committee, and now we're bringing them.
Came up through finance committee, and I would make a recommendation to the board. In fact, I'd make a motion that we go ahead and approve this.
Second. Motion
And this
from
is
Brian.
Darlene, I second.
Dan.
Thank you.
Dan. Okay.
Dan.
Second from Dan before Darlene, thank you. So is there any further discussion? None? Okay, all in favor?
Aye.
Aye.
Any opposed? Any abstentions?
I'm going to abstain only because I missed this in the agenda. and forgot to
Okay.
make it consistent.
All righty. Okay, well, thank you all.
Okay.
Good job.
Great.
Becky, anything else?
Yeah, the last thing is the approval of the duplication of funding policy, and we talked to you guys about that last month about, that we wanted to, so we wanted to create this policy, and it has been created, and it has been through the Budget Funds Flow Committee and the Finance Committee, and we have taken, we've taken suggestions and recommendations from both of those committees, and we've made a final version that we would like you guys to approve and eventually Rhonda sign.
And again, Rhonda, I reviewed this in the finance committee as a recommendation from budget and funds flow, and I think it's appropriate. Actually, I like it very much. And I would make a recommendation and a motion to go ahead and approve this as written.
I second. Motion from Brian and a second from Ronnie. Is there any further discussion on this?
Yeah, I just wanted to, I'm a little worried about the extent of which there are, of the use of the IMC funds, only because some of the things also are related to the district dollars. So it makes it sound like, I just want to make sure I'm understanding that the only opportunity that behavioral health agencies would have to do some of this integration work would be under the IMC dollars and not the regular district dollars. And I don't think that was the intention, right? No,
I hope that's not what it says. That's not what I understood.
because maybe I'm not understanding the policy correctly.
So it's an attempt to clarify, Caitlin, what primarily our BHO group can utilize their IMC funding for, because there's a potential, since we have an overlap between behavioral health organizations and PCMH organizations.
Yeah.
So we just want to be able to leverage the funding as much as possible so that they wouldn't, overlap.
You can't charge one activity to both sources.
Right. So like if I just, from an example standpoint, if they use the IMC dollars for the technical assistance related to managed care business processes, and it was like all dedicated to that, then any district dollars that they got, I'm just separating that out in my mind, even though it's the same pot, but any district dollars they got, they could use on the MEHAP because they did not use their IMC dollars for that. Is that right?
Yeah, but they're getting money for the MEHAP, but that's
what I was, okay, but it's out of a separate pot and it's not related
No,
to
that
IMC.
MEHAP is from the IMC.
Oh, see, now I'm so confused.
Yeah, that's what I. So let's say though that you had an organization like the Practice Navigators go to comprehensive mental health, who's getting funding from the PCMH side and the IMC side. So if we know that we're paying them $10,000 because they've completed the MEHAP, we would not pay them $10,000 to complete the MEHAP through the PCMH process. So just to ensure that there's more funding available for everyone, and that they're not double dipping.
Yeah.
Not that you would, but you know,
No,
just trying to to try to avoid that conflict.
Yeah, and make it so that they can access multiple buckets
For the
dollars
same thing.
depending on their services.
For the same activity, yeah.
And then,
Because it's very intentional when they map it.
Right.
When they declare what they're going to do.
okay, that's
Yeah.
helpful. You feel good about that stuff. Okay.
Yeah,
We were trying
I thought it
to
was worded a little in a confusing way, but if people who are actually going to be benefiting and participating within this space and they don't have kind of concerns with respect to the language of the policy, then I don't have concerns with it. I just, in reading it, it was, and I know that I sat through two of the discussions, and it was confusing to me to sort of read some of it, and felt like if I had been a behavioral health provider coming into the discussion and not having been part of some of the board discussions, could potentially feel limited in what I might be able to do. And so it was just a caution, I guess, of wanting to make sure that that was clear, because I know we're not trying to create undue burden or anything like that. It's just that you're not getting two $10,000 payments for completing the same performance metrics.
That was or if there were two $10,000 charges, they were for fairly different achieved milestones
Correct.
related to the project.
Right.
Okay, any additional discussion? Everybody ready to vote? All in favor?
Aye.
Aye.
Anyone opposed? Anyone opposed? Okay, policy passes. Thank you.
Thank you.
Anything else, Becky?
No, ma'am, that's all.
Okay.
Thank you.
Okay, is Sam on the phone?
Rhonda, are we not approving financials? I know we didn't really go over.
Oh,
them.
I thought we did.
Oh, okay. I didn't hear a motion on that, so.
I thought we did. Brian, do you have those?
We have a motion to approve the, motion to.
We did the
first
funding
document that we
recommendation.
looked over, which was the provider engagement fund formula, and then we approved
Sorry.
duplicate funding.
Taking all these things off here.
We need the financials.
We didn't, okay, so Brian, you brought a motion, right, to accept the financials?
That's correct. Well, I can certainly bring one. I've reviewed the financial statements in the finance committee the other day. Thank you to Becky and her team. And I'm comfortable with everything that was presented. I think the numbers are correct, and I feel I'd be happy to make a motion to accept the financial statements as written.
Okay, is there a second?
I'll second.
Thank you, is there any discussion on the financials? All in favor to accept the financials?
Aye. Aye.
Aye.
Thank you, guys.
Anyone
Thank you for all
opposed?
your work.
Any abstentions? Okay, thank you.
You're welcome.
Okay.
That's good.
So Sam is slated to talk about the PCMH tracker. Are you with us, Sam? Are you muted, Sam?
He was. I can take this, and I can get help from my practice transformation navigators. So as we were working towards the implementation plan, we realized that we needed to have, the steps laid out so it was very obvious to our organizations what was coming up. And so this is basically just a tracker with a list of the steps that will occur during the time between our first meeting and then when you are well down your road to PCMH recognition. And it just is a way to keep track of everything. So you can see that some of the organizations have received a lot of these services already, but there is a lot to be done. I think that there's probably been more steps completed since this was produced last week, because every day the practice navigators are going out and into offices and completing many of these steps. But it just gives you the scope and the breadth of work that needs to be done.
So to highlight the colors here, the provider groups that are in yellow, I think we may or may not have talked about this, relate to those that we hope to complete before the end of next month.
Yes.
And the ones that are in blue below that are to be completed by the end of the year. And the ones that are highlighted in red were initially identified as being exemplary, high-performing organizations that might offer assistance and best practices to some of the other PCMH organizations that are going through practice transformation.
It's just a point of reference.
Yeah.
Good.
Is there any type of like a key code for this top column here that folks will be getting? I know I understand some of it, but maybe not the definition of all of it. And in the past, that's always kind of been helpful for everyone at the table.
So all the PCMH organizations are actually going to receive a guide. It's many pages long, and that's how we extracted some of these steps, is from the guide that Sam is creating. So, but this is just more of an internal document for us that we can fill out, but each organization will actually get this guidebook. And then the other thing we should probably point out is towards the end, it says ED and follow-up ABC and resources for care coordination. At that point, that's when our provider organizations will determine which 3 measures that they want in these areas, because we'll have to be tracking measures. And initially, we'll have all the paper reporting and some paper performance measures that we'll want all of our PCMH organizations to report on. That will be somewhat a negotiation between GCACH and the providers.
Okay, very good. Any questions? Cross ACH list of common training.
This will be very quick. You'll see this beautifully rainbow-colored document. This was the work, it's a joint efforts of all of the ACHs across the state. And you can see where we have all indicated interest in certain trainings. The C stands for contract, the I is interested in contracting, and X is thinking about. So you'll see primarily the only C's that Greater Columbia has is with the contract with Hindsight Healthcare Strategies, who you will get to meet Mike Hindmarsh next Thursday at the celebration. But we have contracted with him for some of the change management, and he'll be helping with PCMH and perhaps reviewing our implementation plan. We took out the Jedi mind control column that Elliot had put in there. Because we would like to somehow control everybody's minds, but we decided that wouldn't be a good training. But you can see that there's a long list. So the idea behind this is that the ACHs can combine forces and have some joint trainings that they could deliver across the state, so not everybody is paying for the exact same thing, and that we can leverage our resources. I would say, however, if you have providers see something that's missing on this list, would be happy to add it.
Okay, I got a question.
Yes.
You have LGBTQ plus out down here, and you say needs to identify a vendor or trainer. There's locally, there's PFLAG, there's Gleason, and then Pride Foundation also puts out training for educational areas. So anything that they would need, and they would partner with others at the local level.
Okay.
To include them. So whatever you need to do under the cultural competency with LGBTQ, you can go through Pride Foundation, I would think would be your first outreach. Okay. And I can get you Tylene's phone number.
Okay.
As a regional coordinator.
Thank you, Ronnie.
Under trauma-informed care, I know CRI does these trainings. I don't know how well developed they are. And I don't know if that's relevant to this one.
Who was it? I'm sorry, Ruben?
CRI community, based out of Walla Walla.
Okay.
We also use Center for Social Innovation. comments on here.
Just as an FYI, under equity, diversion, and inclusion, John Powell, who's the first row there, will be part of the October symposium. I don't know if you want to see anything more about that, Carol.
Just that he was recommended by Liz Baxter from North Sound, and does a tremendous talk on health equity. So
he has a YouTube video that one or two of the EDs looked at it and said he's outstanding.
for those providers and board members that are going to the training in October, he will be our keynote speaker that on the 24th, and then he'll be also available the 23rd for a dinner. So we'll get to hear from him quite a bit.
On the 23rd, so that calendar or schedule is going to be coming out.
So this has gone through a number of iterations, but the final determination is that the 23rd is the training for all of the ACH staff. The 24th is the day for all board members and providers, but the evening of the 23rd is the dinner with John Powell. So if you're interested in attending, we're still taking names. I think we have six board, or between providers and board members, we have 6 people, and then the staff will be going over. So about 15 or 16 people.
Excuse me, Carol. And is there something going on then the 25th? Well, or
The 25th has been dropped off the calendar.
Right, it's just 2 days.
That's what I needed.
Sorry, man.
Keep up, man.
It's okay.
Sorry,
It's
Dan.
off calendar now.
I didn't understand
Okay.
the question.
No,
Sorry.
What? Are we good? Okay, ACH legislative flyer.
This is at the last ACH meeting, only last week. Seems like a month ago. We all adopted a common format to display our ACH information, and this is the template then that we plopped in our information. You might recall, though, ACH, Greater Columbia's had a flyer since the very beginning, and that was the idea of John Sinclair. So this is just the common template, and then the following template is the one that we used yesterday when we were in Whitman County doing the LIN update. So we personalized it a little bit more. We added a lot more detail regarding who the board members are, because that was one of the questions that I got from the legislator when we were in Seattle is, so who is on your board of directors and what sector do they represent and what region are they from? So this is just a little bit more information about each board member and where you come from and what sector you're representing, and then we also included information about the community health fund.
By the way, our presentation yesterday at the LIN meeting was very well received, and it was a good effort by them to put together that leadership council structure from Scott Adams with Pullman Hospital. He did a great job.
He's a nice guy.
Yeah, he is. I think he's getting it.
Yeah, he's a good guy.
Yeah.
Good work. Okay. How to incent the clinical community link.
So we just did, that was actually the book that was the CBO and Partners by
Okay.
NSR.
That's what I thought.
Sorry.
The October Health Fair LIN presentation.
Saw you were down.
Great.
Yeah, sorry, I was reading through all the stuff over here. Yes, the Leadership Council in October, we're going to ask the LINs to do a report out, pretty much to report on the activities they've been engaged in this year, current activities, and to report on their progress on their selection of the third-party administrator, the selection of the social determinants they're going to address. Among some other things. We're also going to have a fair of sorts. We're going to invite CBOs to come in and for the first half hour or so, just have the attendees walk around, meet the CBOs and engage and learn what they do. After that, we're going to have the LINs do the report out. Anything else? Anything that I missed?
And that's at United Way.
At United Way, yes.
Right, and the CBOs will be drawn from the LOIs, but we made the decision to actually expand that list if other organizations who did not submit an LOI wanted to participate as well. So it'll be an open event.
Oh, I have a question, because you just said that the LINs are choosing the TPAs. Conversation you and I had earlier this week was that
The LINs are
the
choosing,
GCACH is choosing the TPA.
the LINs are choosing unless we have a LIN that wants us to choose. So
Okay.
it's,
Yeah.
so there are two LINs that have already chosen. Scott Adams is using the Hospital Foundation, Ben Franklin Community Health Alliance is using Three Rivers. And then we're going through a process of interviewing some of the other third-party administrators for the other LINs.
Have you finalized the agreement?
Have we finalized the agreement? No.
So I think some of us then might be waiting for that,
Yes.
right?
Yes.
Do you know when you're going to finalize that?
We're working on it.
So how could the other LINs have already chosen if they don't have a finalized agreement?
Chosen a third-party administrator because they already knew who they wanted to use for their TPA.
I guess I'm really more thinking about it from the TPA standpoint. They've agreed to it without seeing what they're agreeing to.
There were some LINs that made the determination of how they wanted to use third-party administrator. It's in concert with, the outline that we have, but I think decisions is made financially because one of the TPAs was very high administratively in terms of cost-wise. So there was only one other choice.
So we agreed in principle, and
Right.
the contract is going to spell out pretty much the expectations.
Right, and we have a draft of the contract.
Right.
And we have been communicating with a few of the TPAs and gotten what they would use. And we've also talked to them about if they'd be willing to use our contractor, if they're gonna force us to use theirs. So we're gathering information and we're close. I mean, I don't wanna commit ourselves, but I think we can have it by next week.
Yeah.
Okay.
The cost that they've been charging have been anywhere between 1% and 28%.
Right.
1 in 28?
Yeah.
That's the range.
That's a lot
Very
different.
big range. Right.
I'm kind of feeling really dull-witted right now, and why does this particular piece of work have to have a TPA versus the other work that's gone on?
The community health fund, because the people that are sitting around the table with the LINs will be the ones that will be applying for the funding, and we just wanted to distance them from conflict of interest. So you'll have.
So will the TPA conduct the RFPs and the review of
Yes.
qualifications and all that?
Yes, that's the reason why they were chosen, one of the reasons.
Because I know, for example, there is a LIN that will be applying for the funding. So for them to be in control of the funds and then apply for the funding was definitely a conflict of interest.
Okay.
When we're having to pay people to manage the work, I'm wondering if we made it too complicated.
Well, either way, they would have had to pay ACH to handle the work because there was no way we could take the work on ourselves.
Right.
Yeah, so either they take the administrative fee or we do, and it would have been just easier to have somebody who, this is their core competency, do it. Plus, by having an independent organization, they might open it up to other organizations within their service area that the LIN and the GCACH are not considering, but they're familiar with, that meet those social determinants of health.
Okay, we have 10 minutes left. We're going to motor through the last item, the practice transformation kickoff celebration.
So that's just a reminder. We will have our kickoff, if I can bring it up. We are having our kickoff celebration next Thursday. I believe we've heard from all of you now. So it's 5:30 to 8:30, and it's at the Walter Clore Wine and Culinary Center. There'll be dinner, appetizers, water, and soda.
Cabaret. It'll be
Are you
awesome.
planning on getting on the table and dancing?
No, but I know someone. Kind of married her.
We actually do have some entertainment though.
See?
Wes knows people.
Actually, Carol does.
You can demonstrate your pepper eating abilities.
I'll do that competition.
Sorry.
just out of kilter.
We're also hosting a dinner the night before with Mike Hindmarsh, and you are all invited. I've heard from a couple of you, but we'll need a final answer by tomorrow if you can attend.
If you can't make the 27th, the 26th is an option.
Mm-hmm.
So that's Wednesday and Thursday next week.
Mm-hmm.
The Wednesday night dinner will be at Tagaris over here in, is it Richland or Kennewick?
Richland.
And they can attend both, right?
Yes, they can attend. You can attend both.
Are you going to?
I'm sorry for being so
Policy. I'll see you.
Okay.
If you can't come here, you can come here. It's like, what?
It was kind of confusing. Sorry about that. But yes, you can attend both if you'd like.
Mhm. Thought you were
Well, it'd be funny
worried
if you
about
guys showed
overload.
up and nobody was there. You know, that would really be bad.
Okay, so we have 10 whole minutes. Is there anything that anybody would like to go back to or bring up? And Ed's already got the first hand up.
Rhonda, I want to come work.
Okay.
Because I'm normally a Little Dark Storm Club. Today, so our license for our Waypoint residential treatment facility came through yesterday. We're admitting our first patients today in Walla Walla.
Yay,
So,
congratulations.
8 beds of crisis stabilization and 8 of institution step down. So
Awesome.
it's been a long wait with lots of bizarre delays. We were supposed to open the first week of July, so
Where's it at in Walla Walla, Ed?
it's in College Place actually, and it's 1250 Commercial Way, which is, there's a Honda dealership, and then there's this beautiful new building that's empty for 2 months, and that's us. And so we have our we've co-located our housing and recovery through peer support team, our access to recovery team, our designated crisis responders, and our supported housing team will be the supported employment team, and our crisis residential services. So it's one stop for that book of services. So
Awesome.
really excited. So move down the hill.
That's great.
Well, our main outpatient offices will stay over on Kelly Place. So
Great.
that's good.
So Rhonda, I want to come be one of your care coordinators. Looking for a new job, and you said there was only 20%, right?
At the
Yeah.
data reform conference last week, I attended the ACH update that former Senator Parlett and Allison did, and our practice transformation work group got a call out in terms of a best practice.
Wow.
So
By whom?
they had actually on their slide and in their presentation.
Wow.
Yeah, how about that? Huh?
Awesome. Go team. Yeah.
Nice.
Very good. Anyone else with any updates?
Just something really quick. You might have gotten an email, and Megan DePaul is probably still on the phone, but they're going to have a presentation on Blue Zones October 4th,
Right.
from 3 to 5. So you might get an
That's
invitation.
in Walla Walla. That would be exciting.
I have a suggestion. We should have figured out how to do that 9 county-wide instead of just in one single community. I mean, anyway, there's so much wrong with that. How's that for being? I'm taking over the.
You're taking over his black cloud.
I'm taking over your negative.
I think we have to be
Could I
confident. We
suggest
need to
that
be
when Becky
demographically
sends out the notices for the next payment through the portal, that she might give us all a heads up, just so that we know it's not part of the hacking?
I do, but
Okay.
you might not be on that distribution for
It's
your.
Anita. It's whoever's listed on the
Okay.
portal.
Whoever's, emails in the portal.
So everybody knows about the hacking attempt that happened at the last month, right?
Yeah.
So that we know that the next time it might be real. The money might be real, I mean.
Yeah,
So-
so Rhonda and I and some of the other ACHs received this email from ClickAttack, this person named
Schemania. That's
Schemania. That's right. About
Why do you know that, Ed?
I know. He read the email. So that there was a receipt. You know, there's a receipt for you, and I'm like, I wonder what this is. So I actually called this guy, Adam, whatever his last name was, and left him a message, and it was a hack. So when Rhonda got it, she sent it to me and said, "Is this real or is this fake?"
Well, it's our IT person was
Yeah.
the one that discovered it. So
No, it was a fake, so don't open names.
We wanted to talk about scary information systems. Finley has been fighting an internal virus that got hit, and they're hit since the day before school started. Every time they get it fixed, within a few hours it's back. They're having a very hard time. So if you're sending something to Finley School District, it may not go to somebody, or that person may not have a computer, or, I mean, it's really, and if you get something from Finley that asks you to open it, don't open it. Is it ransomware?
Okay.
I don't think it's ransom. I don't know what it is. I just know that it's just, I mean, they rebuilt and it comes back.
So I guess lastly, let me just ask in 5 minutes from the staff, is there anything that you're waiting on from any of the board members that you just want to call to our attention?
Just call me out.
Do we have all the questions that we need? Did we hear from Les?
No, we didn't hear from us.
Les Stelmacher.
What?
Good.
Will you be attending next Thursday?
I'm trying to work out a conflict. That's why.
Okay.
Yeah, I might not as well do that either, so I'll go ahead and I'll attend.
I want to. I just don't.
Which night? You guys don't have two options for dinner, you know?
They're both ending up being.
Yeah, I'll do both.
You'll do both?
And I want to say one more thing about the party and the budget. Last month, the board approved a $10,000 budget for this party. And Lauren has been doing a very excellent job of making sure that we are staying within that budget.
Thank you. Thank you, Lauren.
It's hard.
It actually is
Seeing
very
those
hard.
go a long ways,
Yes.
but with that many people, it really is.
Being eaten up.
Yeah.
Very carefully, but
Literally,
quickly, yes.
Catering is taking up most of that.
Yeah.
So thank you, Lauren.
You all know
Thank you.
catering.
Okay, well, really good meeting today, everybody. Thank you very much. Until we meet again, which will probably be next week.
For some of you.
For some of us.
Yeah, thank
Have
you.
All right, thank you all.
Sure.
Rhonda, I think I'm going to go ahead and
Oh, Becky, yeah.
not go to the